morning, and welcome to another episode of Health Talk here on AM 1270 and 96.5 FM KXBX. I'm Paul Thomas, and Bill Kearney is in the studio with us once again for another pre-recorded version.
Yes, sir.
You are, at this point, still in Hawaii, right?
I think I am.
Yes.
And
then next week, we'll have another one because I've got jury duty.
Yeah.
So, things that, I don't know why Wednesday's such a popular day for. I know it's always jury duty. Always is a Wednesday thing here in Lake County.
Yeah, it seems to be. I don't know, and then it's over on Thursday afternoon or Friday afternoon, and they still don't have a jury yet. So.
Oh, is that? See, I've never gone beyond the I've sat there for a long time, but I've seen juries get picked, but I've never been picked to be on one.
I got really close once, but in my experiences in the retail field and in the medication field, I've come across enough of the people that are going to be on trial that I'm a little bit prejudiced about. When I find out what they're being charged for, I probably am too opinionated to be objective. So. And now that I'm over 70 years old, I don't get called anymore. I could.
Oh, is that the trick?
Because
I just got one. It seems like I got one just last year probably.
Well, they count it. If you go through that process and aren't chosen, that counts as your appearance, But that next year rolls around really fast.
It
you
does,
just don't realize it. And there's a lot of people that just, they get subpoenaed and they don't show up. So,
yeah, I know somebody who's told me that, if it's never found in the mailbox, how do they know, and that kind of a thing. And
yeah.
I guess I'm too honest for that.
I am too. Plus, I don't want to be standing there one day filling the prescription and the guy comes in to serve me a notice that I'm under arrest for whatever it is, your failure to appear. So, well, we're going to be talking about your health today, not specifically your mental health, but some things. If you remember last week, just as we were ending, we were talking about PSA screening for prostate cancer. And in the last 10 years or so, there has been a huge amount of publicity over whether or not the PSA test was reliable enough that it was saving people's lives. And I think in 2012 they concluded that there were more risks than benefits from screening American men for prostate cancer with the PSA test. And then in April of this year, the Preventative Task Force dumped the decision squarely into the laps of the patients and their doctors. And some men between 55 and 69 years of age might well decide to get their PSA checked. After hearing the ledger of pros and cons, the others in the age bracket might just as reasonably skip the screening test. And one of the things that happened, if you're not of the age to be concerned about this, if you're a female and not a male, you've never really had the PSA test or been concerned about it, but there was a lot of publicity about it not being accurate. And then, and especially error on the high side. And then what happened about 10 or 15 years ago, for some reason, the urologists and the surgeons got very active in pursuing doing biopsies and things on somebody that had a PSA, a high PSA, rather than waiting a while to see if it was aggressive or not. Now, in the past, we realized that all males age 70 or 80 or over are going to get prostate cancer at some time in their life, and it's never been aggressive, or a very small percentage of those people have had an aggressive form of prostate cancer. So the message by the medical profession was just let it go. You're going to die from some other cause besides prostate cancer because it's so slow growing, it's not going to affect your lifespan. So they started getting really active pursuing it. The more biopsies that were done, the more aggressive it seemed that the cancer was. Whether or not they were having biopsies that activated the cancer molecule in the prostate, we don't know. But there were a lot of people that went through unnecessary procedures because of the unreliability of the PSA test. It is now gone back into fashion to say that it's more accurate, but we had people who lost their prostate. It was removed, that immediately had erectile dysfunction and a lot of mental anguish that went with that. But this new research that was published this week in the Annals of Internal Medicine now calls those recommendations into question, and concluded that screening men over 55 can significantly reduce the risk for prostate cancer. There is a growing doubt about the value in the last 10 or 15 years of getting the PSA test, but the result is that there were lives saved. So the news published also underscores the value of prostate cancer screening tests, which rely heavily on which men you screen and where and for how long you conduct the trial and how you crunch the numbers. So this becomes a mathematical quiz as well as anything else. And in the end, the Vanderbilt University urological surgeon, Dr. Chang, was the new analysis, said that it reinforces what urological surgeons and treating physicians have thought all along, and not that they have cancer, but the PSA screening is helpful. But then he questioned, is it really helpful? When it focuses on the right men, it is, and those are the men between 55 and 70. When it's tempered by an understanding that not all those findings are should be treated aggressively. And I had some friends that, and way too many of them, in the last 10 years that have been treated aggressively for prostate cancer, and I'd never seen that before, never heard that before. I even have relatives that were involved, and very painful processes that left side effects. Sometimes Dr. Chang said, who wasn't involved in the study, that a man will get a problematic PSA test and decide not to act immediately or aggressively, but knowing there's a decision to be made is probably a better basis for planning and not knowing. So over the past 5 to 10 years, there's been a better understanding by everyone about the harms of over-treatment. And you don't know how good this makes me feel. I don't know if I've had prostate cancer or not. I have a PSA test, and it always comes out okay. I know people that are friends of mine and related to mine and neighbors of mine that have had PSA tests, that the first time it was high and they started doing therapy with radioactive devices and surgery, and had rectal bleeding after that for a period of time. So there are two groups in particular, African American men and those with a first-degree relative who died of prostate cancer. And knowing your PSA value is especially important because the risks of the aggressive disease in those populations is much higher than for others. So neither group was the subject of special attention in this newly published analysis. Unfortunately, the way screening has been implemented in our country leaves much to be desired. The controversy about PSA-based screening should no longer be whether it can do good, but whether we can change our behavior so that it does do more good than harm. It's the most common non-skin cancer found in men, affecting 101.6 of 100,000 American men, according to the CDC. And in 2013, the latest year for which those figures are available, and I'm not sure why it's that far back, about 176,000 got a diagnosis of prostate cancer and 28,000 died from it in 2013. But a change in the PSA reading is a highly imperfect gauge of trouble. Approximately 80% of positive PSA tests 80% of positive PSA test results are thought to produce false positives, which create scares that prompt men to get biopsies, and a treatment which carries with it a high risk of difficulties with sexual function, urination, bowel movements. It's often necessary because prostate cancers are so slow growing, they will never make a man sick. So as a result of that skepticism about whether to screen for prostate cancer or whether to treat it, more men are skipping the PSA test. And among those who get it and get back a worrisome finding, fewer and fewer are opting to treat it. Now, as a male, and as a male that's 75 years old, I can really understand this. I'm highly critical of aggressive treatment of prostate cancer, especially with only a PSA high test without repeating that again, without doing biopsies. I just have a feeling about whether or not we should be treating it that aggressively. We didn't treat it aggressively for years. We didn't see a huge amount of aggressive prostate cancer until we started messing around with aggressive treatment. So that doesn't mean that some of those tests can't be validated, but when you have 80% of the PSA tests that come out high are not accurate, then you need to get a diagnosis that you really feel is pursuant to doing something about it. And active surveillance, which is sometimes called watchful waiting, where no more are you likely to die of the disease than the men who got the same diagnosis and treated it directly. So a thing that's, as you begin to age and as a male, that you become quite concerned about it, and especially the aggressive way that we've treated it. You know, if you want to look at it, and I apologize to urologists and surgeons, in a way it seemed to me in the last 10 years as it was a way to, and probably the clinical information presented to them was accurate, but it was a way to generate more revenue for medical expenses, and at the cost of many people that had succumbed to these treatments of going through a very painful time, and are still going through a painful time, sometimes because of the radioactivity, sometimes because of the surgical procedure, mental as well as physical things. And as we have said many times, you need to take charge of your health. And it's very difficult to do when you get conflicting ideas on what to do and what to take, and whether we should take this medicine after we've told you for the last 15 years not to take the medicine, whether you take the PSA test when we've told you that it wasn't highly accurate, but you happen to be in the age range where it's a possibility now. When you get to be 70 or older, seldom do they check the PSA anymore. I know several individuals that are 70 or older that have been diagnosed with prostate cancer, and they're doing nothing. And they see a clinician on a regular basis to check the progress, and nothing has really changed. I'm not saying that's the way it is all the time, but I'm saying that it's really something that requires you being involved as a patient, as well as just accepting what a test is going to give you and discussing it with your physician. It becomes more difficult now, as many of you don't have physicians and you're seeing a clinical physician or a physician's assistant that really doesn't know what to do because healthcare is changing a lot. And to make that decision, and it's so protective of the clinician to go ahead and be aggressive, so there's no guilt if you happen to really have an aggressive form of prostate cancer, and they've gone through the procedures to take care of it. So it's like having a ablation therapy instead of just going through and blowing a bubble like angioplasty and getting the clot out of there, or the residual out of there, and not doing something to stop the arrhythmia. So we'll let that go at this point, and hope that you take that information as everything we give you and digest it and research it. And again, these are just reports that I get. They aren't state of the art. They aren't the standard of practice by any means. They're what somebody has reported, and if the report is large enough, then we get a lot more out of it. Yesterday I was looking through the New York Times, and there was an article about city officials in San Diego declaring a public health emergency last week over an outbreak of hepatitis A that has been linked to at least 15 deaths and over 400 hospitalizations in the San Diego area. Hepatitis A is a liver disease that affects the liver and started last November with the homeless population, affected most. And the emergency declaration would help the city access state funds and provide legal protection for the new sanitation measures. Where there are high concentrations of homeless people, they seem to accumulate diagnosis of hepatitis A and things, and they're trying to get homeless people to receive 40 portable hand washing machines to help combat the disease, which can spread the fecal matter, which people fail to thoroughly clean their hands after using the restroom, if they do use the restroom. They also plan to use bleach-spiked water for high-pressure washing to remove all feces and blood and bodily fluids on contaminated surfaces, according to a sanitation plan that was outlined for San Diego last Thursday. Other cities in the region can expect to see similar hand washing and street sanitizing efforts. After a previous vaccination and educational programs failed to significantly reduce the infection rate there, and deaths reports spiking in recent weeks, San Diego decided to mimic a campaign that was used in Los Angeles, which is home to tens of thousands of homeless in an attempt to curb the outbreak. We know that LA has no local cases of hepatitis, which just seems very unusual to me, or hepatitis A, related to the strain that they were seeing in San Diego. And if they're doing it there, they haven't had any cases that could be beneficial as well. So that moves in San Diego follows finger pointing between the city and county officials, with both sides insisting that they were doing their best under tough conditions. There's no recent precedent for this. The homeless population has increased substantially all over the United States, all over the world. They will definitely have to have a plan of action or a playbook to have something like this in the future, but it's the first time they've had something of this nature happen. So as we realize all these diseases that at one time were not prevalent anymore have started to become prevalent because how situations are changing in our world, and we have to do something to combat that, and sometimes we have to wait until there's a major amount of deaths associated with it, as we're finding out with the opiate situation, and we do something about it. One of the things that we vaccinate for and immunize for is pertussis, which is whooping cough. And that didn't used to be an issue, and now it's become an issue every year. In fact, if you're in 7th grade, you have to have a pertussis shot before you go to school, if you haven't had one before. If you're pregnant, you need to get a pertussis shot, a whooping cough shot, every year that you're pregnant, regardless of if it's year after year after year. You have to get it year after year after year. At the time that we might be exposed to something like that, and we didn't have a shot, we speculate on if there are people around you coughing, excuse me, like that, only much harsher, and somebody around you has acquired the whooping cough. You always wonder whether you should get a shot or not, or how long does it take to incubate. And I had a customer come in today that's been very loyal to this radio program and very loyal to our pharmacies, and asked me what the exposure time was from the time you're exposed to pertussis till the time that you could get it. And she couldn't find it on the website she was looking for, so I went in on a specific website and found out that it was excuse me, I don't have pertussis, but I have an allergy to something. And I found out that it was between 6 and 20 days after you were exposed that you might get the whooping cough, but usually within 7 to 10 days. And it had been a considerably longer time with this individual, but you can tell that you can, as you start thinking about this and become more educated, you become have more anxiety about being in a situation like that when you really don't know. This person was diagnosed later, not my customer, but the person who really had the pertussis, and and they, of course, this was on an excursion where they didn't know the person, and eventually they separated from where they were, and then the anxiety starts about what should I have done. In looking at this website, what they suggested was go on an antibiotic treatment immediately after that, and that would prevent many times you getting whooping cough in the following few weeks, even if you had been exposed. And these are very tiny droplets of molecules of pertussis that when somebody coughs or sneezes, that you could inhale and cause you to get that. Now, just because you didn't get it and haven't had a shot doesn't mean you will never get it, but the chances are greatly enhanced when you're very close to somebody like that. So just in the future, if you're, and I always learn something from our listeners. I was recently at a function at the fair, and this individual came up to me and said, you know, I don't listen to you all the time on the radio, but I had the opportunity today when I was getting ready to go to work, and I listened, and you were talking about something I knew nothing about, and she said, I just want you to know, even though I don't listen all the time, every time I listen, I learn something. And she said, thank you so much for continuing to do this. And we've done it for, I don't know, Paul, we've been trying to figure out, but I think it's about 30 years. Mm-hmm. And it just makes me feel good to know that this little sacrifice that we make every week to present information like that to you, that that you all are getting something out of it. So we really appreciate that. There are 3 common medications that you're probably making mistakes when using these medications, and they're very basic, and you don't think about it because you use them so often, and you observe the side effects when you do. The first one is asthma inhalers, often deployed improperly, resulting in as little as 7% of the drug making it to the lungs. And that's just a new study. We've known for years that people don't use them properly. They, to the point that when I dispense an inhaler, I ask the patient, do you know how to use this? And they say, yeah, my physician told me. And I said, well, you tell me how to use it. And they will struggle to tell me, and they tell me what they think it should be, and if the inhaler says 1 to 2 puffs every 4 to 6 hours as needed, it doesn't tell you to wait, hold it in your lungs for at least 10 seconds, wait 30 seconds, and repeat it. It also doesn't tell you to shake it up, but there's an auxiliary label on there that says shake well before using. If not, you just get the propellant that the medication is encapsulated in. And that's not the only medication that's being misused on a regular basis, but then you take the deep breath, you get the air out of your lungs first, you shake it up first, get the air out of your lungs, you push down and get the air into your lungs, and take that deep breath when you get it to saturate all that lung tissue, hold it in there for at least 10 seconds, and then let it out, wait 30 seconds, shake it up again, take all the air out of your lungs, push the nozzle and get it back in there, and then hold it in there for 10 seconds and let it out. If you shake before every puff when required, breathe in and press the button simultaneously, hold your breath for 10 seconds so the meds reach the lungs. Now, what's the disadvantage of not doing that? Number one is you're not getting the medication. Number two is you're likely to be prescribed a higher strength of an inhaler because this was not being effective. Number three, you could be prescribed another inhaler along with it. So if you do all of those things, shake before every puff, when required, breathe in and press the button simultaneously, make sure the air is all out of your lungs, hold your breath for 10 seconds, and after so, the med can reach the lungs. If you do all of that properly, you're getting the maximum amount of that medication that can be inhaled. Eye drops, the air is letting them fall into the inner corner of the eye. I am very bad about putting it in the corner of my eye because sometimes I have contacts in. Number one, you're not supposed to have contacts in when you put the drops in your eye. If you put them in the corner of your eye, that's a passageway to your nose and throat, and you know if you get a stuffy nose or a strange taste in your throat, that's what you've done. The fix to that is using a finger to block that corner and then aim the drops for the center of your eye. Close your eye for 30 seconds. You'll be amazed at the difference in the effectiveness of that. The last one is a nasal spray. Excuse me. The biggest problem is not blowing your nose before. You have to get that existing mucus buildup out of your nasal passages because that will prevent it from absorbing and working properly. The fix is to blow both sides of your nose even if you don't feel congested. Then hold one nostril closed while you inhale the spray on one side, and then hold the other nostril closed while you dispense it on the opposite side. Just remember, if you're using a steroid spray, you're going to get maybe a little bit of irritation from the steroid spray when you first start using it, meaning it will redden that tissue on the inside. Make sure you wash out that inhaler before you put it away. And if you're using oxymetazoline, which is Afrin nasal spray, and anything that says they're 8 to 12 hours acting, you can only use that for 72 hours on a routine basis because you will start getting a rebound effect from using it too frequently. So after those 3 days, if you're still having the situation, get some ocean spray or saline nasal solution that's a moisturizer also, and use that instead. If you continue to use the oxymetazoline or the Afrin or the neosynephrine long-acting or whatever long-acting medication there is out there, you will be using it every 30 seconds just to breathe because that rebound actually shrinks that nasal tissue where you need to use more medication to keep it open. We're going to take a break, and when we come back, we're going to talk about what Australia's bad flu season means for Europe and North America. Have you been to the pharmacy recently where the employees know your name when you walk in the door and have your prescription refill waiting? If you answer no, then you probably haven't been to one of the Northlake Medical Pharmacies. Hi, my name is Bill Kearney, owner of Northlake Medical Pharmacies. For 38 years, my wife Dana, our daughter Brandy, and our employees have been dedicated to giving you the best service we have when you come to get your prescriptions. We are a family-owned pharmacy, and our employees are members of the Northlake Medical Pharmacies family. We know you have a choice when you get your prescriptions filled, and we appreciate you making us your choice. You see, you are part of our family too. We truly care about your health and taking care of you when you aren't feeling well. We deliver your prescriptions free when we know ahead of time and do the best we can to take care of you and your family. Northlake Medical Pharmacies with 2 locations for you, on Hill Road across from Sutter Lakeside Hospital and 347 Lakeport Boulevard outside the Bruno Shop Smart in Lakeport.
This is the Caltrans Road Information Bulletin for Lake and Mendocino County State Highways for the week beginning Friday, September 8th. In Lake County, on Route 20 near Clover Creek, weekdays, expect 10-minute delays. On Route 29 near Hofacker Lane, weekdays, expect 10-minute delays. And on 175 near Arroyo Vista Road, expect 5-minute delays weekdays. In Mendocino County, on Route 1, expect 5-minute delays at a few locations. On Route 20 near Little Lake Road, beginning the 13th, expect 5-minute delays weekdays. And near James Creek, weekdays, a company could cause 5-minute delays. On Highway 101, expect weekday delays in multiple locations throughout Mendocino County. On 128 near Shearing Creek, weekdays, expect 10-minute delays. On 162 west of Pukani, weekdays, expect 10-minute delays. And starting the 13th near Outlet Creek, expect 5-minute delays. On 175 near the Lake County line, expect 30-minute delays. On 253 near Singley Cattle Pass, expect 15-minute delays weekdays. And that's it. Like us on Facebook for more updates. That's Caltrans District 1.
Come join your neighbors on September 16th to clean up the Russian River and creeks and protect the health of our watershed. Meet at 9 a.m. to 1 p.m. at Oak Manor Park in Ukiah or at McCarty's Barn Grill in Redwood Valley to join teams and pick up litter. Last year, 140 volunteers collected nearly 2 tons of trash and 1 ton of recycling, and we can do it again. Come prepared to wade through water along uneven rocks or through thick shrubs. No flip-flops. For more information, call 462-3664 extension 106.
Raising your family, tending to your animals, growing your own produce, preparing for the seasons, living the country life. Hi, I'm Jody Henke, host of Living the Country Life. Catch me every Monday through Friday at 9:35 a.m. and 4:35 p.m. for ideas and inspiration for your place in the country. That's Living the Country Life here on AM 1270 and 96.5 FM KXBX.
We bring the community closer together, supporting business in every way. We're helping make your dreams come true, working hard for you.
The Lake County Chamber of Commerce would like to recognize their Member of the Month Business Design Services. Robert Bocabella, BFA, is principal and founder of Business Design Services and is a certified interior designer in private practice for over 30 years. He provides designing to fit the vision in collaboration with writing service at earthlink.net. To contact him, call 263-7073 or email him at rb@businessdesignservices.com or visit his website at businessdesignservices.com or on Facebook at Business Design Services.
Lake County Chamber of Commerce, we're steady and strong, help us shape the future.
Yeah.
All right, we're back.
Well, I mentioned before the break we were going to talk about Australia's bad flu season and what it means for Europe and North America. The reason this was significant to me, I last night had dinner with one of the former national or international water skiers many, many years ago when I first came up here. And Mick travels a lot, and he gets all kinds of diseases from traveling, nothing very serious, but there were a total of 52 deaths associated with influenza that have been reported in Australia this year, compared with 27 at the same time last year. There's also been more flu-related hospitalizations, 1,429 versus 719 in the last year's surveillance report. So there's nothing really unusual about this year except that it's a high year in Australia, which is what you see every once in a while. Australia's curve is clearly much higher than the curve of last year, and we suspect that that's not surprising because the U.S. government's own webpage for 5 to 6 years worth of influenza case curves showed clearly that they're all over the place. There's a tremendous amount of variability when it comes to countries. All the flu people say that the only thing you can predict about influenza is that it's going to be unpredictable. Australia's states breakdown reveals that New South Wales, the nation's most populous, is battling the most cases of flu, which is 60,000 as of the end of last month. August has proved to be the worst month on record for New South Wales. Government health data shows 35,670 confirmed flu cases, most of them in Sydney. Previously, the worst months in New South Wales had been half of that, 16,686. 2016, it was 13,000. So remember now, that's the winter months there, not the summer months like it is here. Their seasons are the opposite of ours. So it's probably not a reliable way to judge the severity of the season unless other factors such as testing practices are taken into account. Hospitals have been using more sensitive tests, so flu cases that are previously undiagnosed are now diagnosed accurately. But the high number of cases this year, particularly on the eastern seaboard where New South Wales is located, has caused them to have some concern. An earlier onset this season has contributed in part to the increase. The influenza A, which is the predominant circulating influenza virus nationally this year, most of the deaths were due to that strain. There are A groups of viruses and B groups. The A groups are the one that usually are responsible for the large epidemics. And although those A strains change periodically, they're the ones that cause pandemics, and that's when it becomes an epidemic proportions, where the B strains usually kind of just pedal along and never really get aggressive. They always cause illness, but it can be just as severe as the A strains, but they don't have large outbreaks. In the northern hemisphere flu season, A starts early, causes most of the cases, and then usually abates, and we look at the late season influenza where most B strains are added. Each year, that vaccine is made for the southern hemisphere and for the northern hemisphere from a combination of A and B strains. They consider which viruses are making people sick, where those viruses are spreading, and how well those previous seasons' vaccine protected against them. Sometimes each hemisphere's formulation is different, but sometimes they're identical. In Australia, it indicates that the 4 flu strains in the vaccine were well matched to the circulating viruses. It is known that one of the strains in the vaccine, which is H3N2, is less effective, and despite a good match. So, and as we told you last week, the vaccine for children, which is an active vaccine that is in an inhalant, will not be available this year because its protection last year was 0, and it appears that this year it's going to be 0. Then you wonder, does the Australians' bad flu season boodle ill for northern hemispheres, including the United States, Canada, and across Europe? In general, we get in our season what they get in their season, and immediately preceding us. And an intelligent guess, therefore, is that the North will probably have a bad flu season. Now, we don't know that for sure. We're just talking about what could happen. And that brings up the idea of people asking about flu vaccines. I know some of our competitors are giving flu vaccines now. We will be getting it in the next 2 weeks. We encourage people not getting it until the 1st of October or the very last of September because the potency wears out over a period of months. And if you get it too early, when we get into the critical part of our flu season, the strength of that vaccine is much less than it was in the very beginning. And so if you get it in October, November, December, January, February, March, you have 6 months of a high circulation of vaccine in your system. If the strain has changed, that's a different story. The high incidence may have never been due to changes in the makeup of that virus, the part of the virus that makes it easier to infect people who have been exposed to the strain or have been vaccinated if the influenza vaccine is not matching the circulating strain. So that could explain the larger incidence. We don't know that. We assume they match up great, but, as we've talked about, it's a guess. And how many people were sick last year also matters. And the circulating strains this year are the same as last year, and relatively few people became ill last flu season. I think the illness came after the season rather than during the season. There will be fewer people with natural immunity in Australia, so they wound up getting hit now. Meanwhile, there's other countries have had more people sick during the previous flu season, so they might have more naturally immune people and will not get hit as hard. So when you talk about flu, nothing is absolutely precision. In general, one can say we usually see here what they see in their season, but that's not a one-to-one correlation. Still hearing about Australia's high number of flu cases, you want to start tightening your belt and thinking maybe that's going to happen to us too. But you want to be covered with vaccine as strong as you can be, and that is to wait a little longer in the flu season. Before I get on the thing about opiates not being the only pain drugs that we need to fear, I saw this yesterday after we'd recorded one of our shows, and it was the first count of fentanyl deaths. And if you listened to our last show, you heard that a lot of the deaths that were occurring were from fentanyl and heroin being injected together. And fentanyl is a drug that used to be used only in a patch called Duragesic for a 72-hour patch to help people with chronic pain. And it really had not been abused and had not been treated as an opiate that was something to watch until they started making illegal forms of fentanyl and combining it with other opiates. The first government account of nationwide drug tests in 2016 show that overdose deaths has grown 540% in 3 years. This is just fentanyl. 540% in 3 years. Drug doses killed roughly 64,000 people in the United States last year. Of deaths, to cover all of 16, it's a staggering rise of more than 22%. Over 52,404 deaths recorded the previous year, 64,000 last year. The New York Times estimates in June, which was based on earlier data. They're expected to remain the leading cause of death for Americans under 50, as synthetic opiates, which is fentanyl and its analogs, and now they have something that's 50 times more potent than fentanyl. They continue to push the death count higher. Drug deaths involving fentanyl more than doubled from 2015 to 16, accompanied by an upturn in deaths involving cocaine and methamphetamine. Together, they add up to an epidemic of drug overdoses that is killing people faster than the HIV epidemic rate. Now, you remember when about 15 or 20 years ago when we discovered HIV was a killer, and we thought that we were going to lose a major part of our population in some areas. We went on a very aggressive campaign to get medication to cure that disease, or at least treat that disease, because we weren't effective in stopping that behavior. This is the first national data to break down the growth by drug and by state. We know for a while that fentanyl was behind the growing account of drug deaths, but now we can see the extent to which this is true nationally. Deaths involving synthetic opiates, mostly fentanyls, have risen to more than 20,000 from 3,000 in just 3 years. If you remember the statistic that I gave you last week on opiate deaths in the state of California, Lake County is the highest county in California, with a number of 50 deaths per 100,000. I know we don't have a high populous state, but our percentage is higher than any other county in the state of California. I just found that overwhelming. We have an obligation to monitor opiate research and opiate training and people withdrawing from opiates to see excuse me, where we need to do more work, and that certainly is a place that we need to key. But opiates aren't the only pain drugs to fear. And this might surprise you some, but last month the White House panel, declared the national epidemic of opiate abuse, and it became a national public health emergency. A disaster is indeed what it is, with 142 Americans dying daily from drug overdoses, a fourfold increase since 1999, more than the number of people killed by gun homicides and vehicular crashes combined. Lest you think that people seeking chemically induced highs are solely responsible for this problem, physicians and dentists and pharmacists who fill those prescriptions lend a helping hand also. The number of prescriptions for opiates have jumped from 76 million to 219 million 2 decades later. But 2 other studies were done to show you an option, probably too often prescribed to people with chronic pain. As with alcohol, opiates are not a problem for most people. Most people fall into the abuse syndrome. But while opiates are now prominent in the national, they are not the only one of many drug-related problems with pain management. In fact, opiates aside, the vast majority of medical difficulties of pain patients encounter the result from the use and abuse of pain-reducing medications that are sold over the counter. And we've seen in recent years that each class of drugs used to treat pain has its downsides as well as upsides. Most people assume that if one pill is good, 2 must be better. This happens periodically with drugs that used to be on prescription, like ibuprofen, like naproxen, like omeprazole, which is the Prilosec, Prevacid, Pepcid, Tagamet. Many people think that these pain medications and non-steroidal anti-inflammatories like ibuprofen and naproxen that they can buy without a prescription is safe. As we talked about last week, there are ones that are not safe, and as George Gershwin once wrote, it ain't necessarily so. A national ambulatory medical care survey said that NSAIDs were used by 95% of the nearly 7 million patients who took at least 1 chronic pain medications, athletes from recreational to elite. I'm not a golfer. Are you a golfer, Paul?
I've gone a couple times,
Have
but
you?
I'm not like fanatical about it like most are.
But you're an athlete. Was an athlete.
Yes.
And most golfers that I know take an anti-inflammatory before they go out. And so they're taking, instead of taking 1 200 milligram ibuprofen, the clinical data says you can take up to 3,200 milligrams a day. So they take 4. They take 800 milligrams at a pop. They don't think anything about it. They're having a side effect to it because it's over-the-counter medication. But athletes from recreational to elite also take those drugs to counter their muscle aches and joint pains. They're powerful medications, and in huge doses. I was talking to a patient the other day that was taking omeprazole and for ulcers, and was taking 4 a day of 2 in the morning and 2 in the evening. Developed some cardiac problems that I think was related to the PPI, to the Pepcid or the omeprazole. Those side effects, and I've said this many times, if aspirin was released today as a non-steroidal anti-inflammatory, which it is, it would be on a prescription because it can destroy the gastrointestinal system. So in addition to cardiovascular risks, non-steroids, even when taken short-term, can precipitate clogging of the blood vessels, damaging the lining of the digestive tract, especially when they're not taken with food. The most serious side effects include ulcers, bleeding, kidney failure, and in rare cases, liver failure. And because of the adverse effects, the European guidelines for chronic low back pain recommend using NSAIDs for up to 3 months. And guidelines on chronic pain recommend the shortest duration possible. Older patients who have diminished liver and kidney function are especially at risk for non-steroidal anti-inflammatory conditions. So, and you think about Tylenol. Tylenol is used probably as much as anything, and acetaminophen, which is its generic form, and you think it's always safe, but it can damage the kidneys when used in large doses, and that might happen for chronic arthritic pain. Acetaminophen is a excuse me, an ingredient in many over-the-counter drugs as well as some prescription medications. So if you happen to be taking a couple of acetaminophen or Tylenol extra strength, and you happen to be taking a Norco or a Percocet that has milligrams of acetaminophen too, or taking a cough syrup that we talked about last week that could have some Tylenol in it, damage can occur. There was a result a few years ago of a gentleman at Thanksgiving, and he'd taken one Tylenol extra strength and had a glass of wine for Thanksgiving dinner, and he woke up 3 days later with a new liver because he got liver damage excuse me, from that little bit of Tylenol and combining it with alcohol. The FDA a couple of years ago said that the dosages above 4,000 milligrams in a 24-hour period is very high, and not to go higher than that. They previously told manufacturers to limit the amount of acetaminophen to 325 milligrams, and reminded healthcare professionals not to dispense medication that exceeded that amount. So we, at times, will call physicians when they're ordering an acetaminophen and narcotic combination that the acetaminophen dosage is greater than the maximum dosage they should be taking. And it's not always a positive result from the physician. I think, excuse me, it will be in the future because of all the connections with opiates and bad situations happening. But it's the acetaminophen we look at for the toxicity more than the narcotic, because the damage done by the acetaminophen or by the non-steroidal anti-inflammatory can be much more severe than the addiction that's going to happen with an opiate. Last week we talked about the amount of contraindications you could get with opiates and what they could do to you other than make you addicted. They can cause very serious side effects also, and many times it's something you can deal with, like constipation or nausea or dizziness or those kind of things, if you avoid what we tell you to avoid, and not be operating machinery, not be driving a car, not be doing those kind of things. And then it ends up that if you don't take care of those considerations, that you're going to have some problems. And just like when we dispense a ibuprofen that's 800 milligrams or 600 milligrams or 300 milligrams, we will tell you, make sure you take this with food. There are times when we tell you to take it with food that have to do with the absorption of the medication, but most of the time we tell you to take it with food is to avoid the side effects that can occur and to buffer the stomach if you're taking something that's going to irritate the gastrointestinal system. There are times that we dispense a medication that really, if you take it with food, enhances the effectiveness of the medication. Some of those are antibiotics. Macrodantin or nitrofurantoin is one of those. Any of the antifungal drugs require an environment that the food offers to help them absorb better and get into higher blood levels. But the main reason is to avoid the side effects that occur with it. And sometimes, for example, sulfa, which is an antibiotic, and you've had a prescription for Bactrim or a sulfa drug, that has 2 different ingredients in it, and we tell you to drink lots of water, and there may be something on there that says to take it on an empty stomach, which is what the manufacturer asks us to do. But if you talk to 70% of the people who take Bactrim DS or any kind of sulfazoxazole or sulfa-based product, they will tell you that they're nauseated if they don't take it with food. So I would rather tell you to take it with food and limit the absorption until it gets a good level in your bloodstream than have you quit taking the medication because the first 2 times you took it on an empty stomach you got sick. And we don't necessarily know that that happens with you because we dispense the medication. It's not refillable. We ask you to take it till it's all gone. We tell you how to take it, whether on a full stomach or an empty stomach. And then we assume that you take that medication. 2 things are important here. Number 1, if you just take a few of them and you don't finish it off, especially if it's an antibiotic, you're in a worse shape than you were if you didn't take any at all. If you're taking something for high blood pressure, which is called a silent killer, or diabetes, and you're not checking your blood sugar and you're not checking your blood pressure, and you just, because of the side effects, which usually go away within 72 hours, you just quit taking it. 50% of you don't come back and get that prescription refilled. Over half of the medication we dispense is not taken by you. So as well as overdoing on prescriptions, we underperform probably more than we overperform. So if you have any questions about whether or not you can take this drug after so long, and many of you cold turkey yourself off medication, which is a dangerous thing to do. Almost every drug you take needs to be tapered off. And a lot of physicians don't understand that either. They'll just say, you know, when you finish this drug, quit taking it. For an antibiotic or something that's taken short term, that's perfectly okay. But if you're taking something as a routine medication, it's going to be very difficult just to take you off at a blood pressure medication like a beta blocker can cause you to have withdrawal symptoms like you would have from an opiate. Not something that you would look forward to. And if Friday night you're taking your last antidepressant and you need to get it filled and you forgot, come in and see us and we'll give you enough to get you by. Same way with the blood pressure medication. You don't want to put your body through 72 hours of something that's very, very difficult to go through, and many times you don't know what's happening and you think that you've done something wrong or you're really ill where you aren't. So we're going to remind you again that we have delivery service to Kelseyville and the Rivieras and Riviera West, the Clear Lake Riviera, and to the Buckingham area. And remind you that we're North Lake Medical Pharmacy with 2 locations for you at 5136 Hill Road East across from Sutter Lakeside Hospital, and outside the Bruno Shepsmart at 347 Lakeport Boulevard. Thank you, Paul.
Thanks, Bill, and we'll see everybody back here again next Tuesday at 10 a.m. for Health Talk right here on AM 1270 at 96.5 FM KXBX Lakeport.